a technique that gives you the greatest density. And you may have a number of different things. And as we go through the semester, it's going to get more complicated. But it'll ask you things like, select the technique that will give you the greatest density, or select the technique that would create the most scatter radiation, and things like that. And you'll have separate KVP, MA, time, irrelevant things like focal spot size, shouldn't affect any of that. You may have a difference in SID by the end of the semester, between different techniques, and you're going to have to be able to identify which one is going to give you the greatest density or the greatest amount of contrast or the lowest contrast. So as we get into the different things this semester, like your grids and things like that, those type of questions get more complicated, but we'll start with KVP and mass for this one. So what we're going to talk about in formulation of technique are patient factors, and then the result of the patient factors on the image with and without technique compensation. And we'll talk about the effects on the image quality factors. And your image quality factors are optical density. You have to have adequate density on the image to make diagnosis. But you can't have too much density at the same time. You have too much density, and density is just that darkening of the image. It's how dark the overall image is and how much light's coming off of your monitor. You can't have too much, and we'll take a look at some x-rays here in a minute and see where we've got too much density. Contrast. So we have to have contrast. Contrast is controlled in really fundamentally by differential absorption inside of the patient. If you have no difference in absorption in tissue types, then you have no contrast, right? So in the x-ray beam itself and in the remnant beam, that differential absorption is what gives you your contrast. Now what displays the contrast is your computer algorithm, that is your lookup table. So you make your exposure and you get a histogram based on the attenuation inside of the patient. It compares it to the lookup table that's stored into the computer. The lookup table is, if you've watched the videos, I kind of briefly described it, but the lookup table, whenever you get a new set of equipment or a new room, maybe they converted the entire hospital to a different vendor, radiologists will sit down with usually one or two radiologists with applications tech and maybe an x-ray tech, and you'll look at representative examples of every exam type. So fingers, hand, wrist, forearm, and so forth. And they've got some images stored into the computer so that the radiologist fundamentally looks at it. They may give 5 different examples of a hand. They'll say, okay, I like, you got 1 through 5, I like number 2 best. So that becomes the standard for which every hand that is shot becomes compared to. So that when you make an exposure, depending on what your KVP and what your mass is, and patient factors, including the thickness that we'll talk about here in a bit, what you get is a range of densities on the image. And it doesn't really make any sense to you. It's just this graph of these lines. But each one of those lines represents a density at some point along the exposure, okay? So let's say that your the histogram that you create whenever you make the exposure on a patient gives you a range of exposures and densities that look like this. But the stored histogram looks like this, okay? So what your computer's gonna do is it's gonna take this and compare the two, and it's gonna adjust yours to where it looks like the one that's stored in the computer. And that's basically how your contrast and density is controlled on your image, is that I don't want to say regardless of what kind of technique you use, because it does matter, but if there are slight variances between what is an ideal technique and what you used, the computer corrects for it in that way. So it's a process that we call automatic rescaling, okay? So you make your exposure, if you've ever paid attention to the computer, you make your exposure, and what you get immediately, you know, as it's kind of loading, is this really great ugly image, right? And that's an unprocessed image. And then all of a sudden, Shazam, it looks good, right? Well, it's because it underwent the automatic rescaling. The raw data is what you see at first, and then once it goes through automatic rescaling, you get the image that actually looks good. Okay, so in the contrast, the reason I took that rabbit trail is because in the contrast, you've got two different things. You have to have that differential absorption. You have to have it, or you have no contrast, right? But the contrast as displayed is dependent not so much on KVP, but rather on that computer algorithm and that stored histogram inside of the computer that we call the lookup table. So effects on image quality factors, we've got 4. We've got optical density, contrast, we've got detail. And anytime you see detail without any kind of qualifier, or resolution without any kind of qualifier, that's actual lines, as spatial resolution, and then distortion. Distortion being misrepresentation of the size or the shape of the anatomy. So your patient factors can control all of that stuff, or at least affect it, and that is that your patient factors body habitus, part thickness, which is not necessarily the same thing as body habitus, body composition, which is sometimes synonymous with part thickness and body habitus. Generally, as we go from asthenic to hypersthenic, generally we gain soft tissue, right? So body composition can be a part of that, but it's not necessarily the same thing. We got pathological conditions that will change body composition in a portion of a part, right? What I mean by that is you've got osteoporosis, you're going to lose bone mass, right? And that will be an example of pathology. So patient factors, we've got different body hapti. We've got sthenic, which is usually thin, described as thin, but muscular, so large average maybe. Then you got hyposthenic, which is thin, more like a runner's build. So the difference between those two would be, like your sthenic patient would be somebody who's more into weight training and things like that, as opposed to a hyposthenic patient would be somebody with a swimmer's build or somebody with a runner's build. Hypersthenic would be very big, asthenic would be very, very small. So your nursing home patients that are kind of emaciated looking, there's your asthenic patients, as opposed to your really big patients, your hypersthenic patients. So thickness may be because of body habitus, it may be because of development, and you know I've been through this in one of the videos, but this is kind of the tie-up to it, so we're going back through it. But you've got hypertrophy and you got hypotrophy. All right, so hypertrophy is development in response to a stimulus. So somebody's doing a lot of weight training, they get big and bulky, right? And if they, take the summer off, what happens to all that bulk? They lose a portion of it, right? So hypertrophy is development in response to a stimulus. Hypotrophy is underdevelopment or loss of development because of lack of stimulus. And it doesn't mean that the patient necessarily went through hypotrophy whenever they lost it, but rather if anybody ever taken care of a paralytic? Somebody who's maybe paralyzed below the waist? Had a patient? Yeah? Okay, well what you see in a lot of cases is their legs and muscles in their legs, because they're not standing up and they're not walking, they atrophy. Okay? So they undergo hypotrophy. Not only do the muscles deteriorate, but the bones do too. So you have what we call disuse hypotrophy, or disuse osteoporosis, basically. So maybe thickness may be secondary to another condition like bowel obstruction or edema, and there's significant difference between those. Edema, what is edema? It's a collection of fluid. So you got ascites, you got edema, you got swelling because of a lot of fluid. As opposed to a bowel obstruction, you know, initially you may think, well, a bowel obstruction, everything stops. So, you know, anything you put into the patient doesn't move. So that's also a buildup of fluid, right? Well, no. In a lot of cases, or in most cases, what you have with a bowel obstruction and how you diagnose a bowel obstruction is abundance of air. So the air is not even passing. So on an upright abdomen or chest x-ray or decubitus abdomen, your telltale sign that the patient has a bowel obstruction is air fluid levels. So really what gives you that bulging belly is not fluid, but air, right? So in these cases, you know, what do you do with your technique? Well, in one case, you got to increase your technique. In one case, you got to decrease your technique, right? Or at minimum, not increase your technique for a bowel obstruction. And you need to be aware of telltale indicators that you know, you've got one of these things going on. And I'll walk through this in the video, so now I can see who watched the video. I can see who watched the video, by the way. What's your telltale sign the patient has edema?
Swelling.
What's that?
Swelling.
Swelling, okay. So in both cases, though, you got swelling, right?
Would it be?
So what about ascites? So the patient's got swelling all over their body. What's your telltale indicator?
Is it the density or is it CD? I don't know how to pronounce it, but is it that destructive pathology?
It's an additive.
Additive.
Yeah,
So
it's an additive pathology. I'm
Right.
talking about in evaluation of the patient.
So
You walk into the patient's room and you see a swollen patient. How do you know that it's edema or ascites versus, you know, it's just their normal body build? Yeah, I heard.
Is it like the color or the temperature?
Well, possibly, but your telltale indicator, you ever mash on a memory foam pillow or memory foam mattress? Does it spring right back up like a inner spring? No, you mash on it and it comes back very slowly. Now, you know, mash on your own. What does it act more like? Memory foam or does it spring back real quick? Springs back real quick. Right, so if you have a patient, you know, you go up to the patient's room and you're evaluating your patient, you look at the patient in their oxygen mask, usually they're going to be on oxygen, and it's mashed into their face, right? And they've got no bones on their ankle. So their calf just goes straight into their foot, and their foot's all swollen. And you mash on them somewhere. I don't mean grab them, but you can just push on them just a little bit. And if you've got indentations in that patient's skin that persist, you mash on it, it doesn't spring right back, that patient's full of fluid, okay? As opposed to a bowel obstruction, what are your telltale signs the patient has a bowel obstruction? You walk into the patient's room, they got a great big distended abdomen. Could be them, it could be hepatitis. It could be, you know, that they just got a great big beer belly. It could be almost anything. But what's your telltale sign that they're full of air?
It's hard.
What's that?
It's hard.
Well, that's actually a pretty good one. But the thing is, patient's fat, depending on where that fat is, if it's below the muscle layer or in front of the muscle layer, it's going to take on a different, I don't know, a different texture. Okay, you ever seen somebody with a great big beer belly and that thing is just hard as a rock? Okay, that's because it's underneath the muscle layer and it doesn't sag. And then you've got people that, you know, they take off a shirt and it looks like they just gave birth to, and these are men, look like they just had a litter of puppies, you know, they just saggy all over the place, right? And that's because it's on top of the muscle, okay? So sort of, but not really. But what your real indication is they've got a bowel obstruction is you walk into the patient's room, they got an NG tube. So they got a feeding tube in their nose. That's not enough. You know, a lot of people have a feeding tube, right? Is that feeding tube, is that NG tube hooked up to suction? That's the second thing you should be looking at. Do they have an NG tube? Is number one. Number two is it hooked up to suction? That's still not enough. Is that suction canister full of bile? If it's full of bile, that means that the bile that they create and they expel into the small intestine is just not going anywhere. So they're sucking it back out, and it's in the suction canister. So, you know, you walk into the patient's room, you take a look at these things, you evaluate your patient. It's what you call triage. You evaluate your patient, and you know, if they've got this big distended abdomen and they got nothing else going on, then it's their anatomy, and there's probably a lot of fluid, as opposed to if they've got those indicators, got the NG tube, it's hooked up to suction canister's full of bile, they're probably full of air. Now, what's even better than taking a look at the patient? What should you be doing before you take an x-ray on every patient, especially portables?
Look at the chart.
Yeah, exactly. Look at the chart. Look at the chart. Why are we doing this? And to take it a little bit further, you walk it, you know, we get a lot of stat portable chest x-rays. You know, patient sneezes and we get a stat portable chest x-ray, right? Sometimes those stat x-rays are for central line placement, okay? So what's the danger in a central line placement?
It could go into the lung.
What's that?
Is it the one that can go into the lung?
Yeah, yeah. Hopefully, you know, even if they penetrate all the way through the subclavian, if it's, you know, subclavian, if they go all the way through the subclavian and penetrate the lung, hopefully they're going to pull it back and they're going to get it into the vein. So really, the central line into the lung itself is not that big of a deal, but they very well could have. Well, it's a big deal,
Right.
but they should have gotten it into the vein. That's what I meant by it's not all that big of a deal. When we get called up to the floor for central line placement, the placement is okay, you know. I mean, it's good to see the placement. The danger is, did they drop a lung? You know, did they dig around in there so much that they penetrated through both sides of the vein and puncture a lung, right? So again, evaluate your patient. You walk into the patient's room and they've got, you know, a sterile tray on the bedside table. And a lot of blood on it. It's going to be blood on it anyway. But the implication there is that they probably put a central line into the patient. So now you got to ask questions. Are we shooting this for the central line? Are we concerned about a pneumothorax? How difficult was the stick? You know, because if it just slid right in, the patient's fine. You know, you're looking truly for central line placement. But if the doctor had to get in there and dig around for a while before he could put it in, now we've got a chance of the patient having a pneumothorax, collapsed lung. Collapsed lungs, atelectasis, but pneumothorax, introduction of air causing that collapsed lung. So ask questions. You know, find the nurse. Say, how hard was this stick? Are we concerned about a pneumothorax? Because it might affect your technique. Not as much now as what it used to with screens and films, but it still could. So, all right, so when they put a central line into the patient, it can go one of two ways. You know, it's going to hit it's going to bypass or enter into other vascular structures. So what if it goes and it hits and goes up into the external jugular, as opposed to going down into the superior vena cava? Is that a big deal? Sounds like a huge deal, right? But is it really? Compared to the collapsed lung, is it really? I've seen them leave it. Most of the time they're going to go in, they're going to readjust it, try to put it in the superior vena cava, but which way is the blood going in the jugular? Is it going up into the brain or is it going down? The answer is right there in the word jugular. Is it vein or artery? It's a vein, right? So which way is the blood going in a vein? Towards the heart or away from the heart? Towards the heart, right? So you push meds into the jugular vein, and chances are it's just going to wash straight back down anyway, right? So depending on how hard the stick was, the doctor might not even readjust that. But if it was a hard stick, is it important to see pneumothorax? Absolutely, absolutely. So you gotta ask questions. You know, why are we doing this exam, and what is the patient's condition, or possible condition? Is it valve obstruction? Is it edema? Are we shooting chest X-ray for central line, truly for central line placement, or to rule out a pneumothorax? Very important in your positioning, in your technique formulation as well. So patient factors, we've got composition, and we're going to refer to this throughout the curriculum. ZEF number. ZEF number is kind of a contraction is Z effective, or it's an effective atomic number. And the actual atomic number difference between different tissues and even different contrasts is very minimal. Whenever we do a contrast study with barium, what kind of KVP do we use? Very high. When we do a study with iodinated contrast, do we use as high KVP? Why?
It's not as hard to penetrate.
What's that? It's not as hard to penetrate, it's not as thick, right? And if you look up the two on the periodic table, the difference between the two, not all that great, right? Atomically, they're not that far apart on the periodic table, which means that their actual atomic number and their absorption characteristics are almost identical, okay? So the difference really becomes the amount of that atom in suspension inside the stuff that holds it, okay? So in a barium study, they pack a lot of molecules together. In an iodine study, they're more dispersed, okay? So that's kind of what your ZEF number is that even though the atomic number of barium and iodine are similar, because we have so much more of it in barium, the Z effective is off the charts compared to your iodine. Does that kind of make sense? So when we're talking about the difference between muscle and fat, both fluid-filled structures, so atomically they're similar, right? But muscle is a little bit more dense. Z effective is a little bit higher, okay? So when we're talking about Z effective, that's what we're talking about, is how dense, not just because of the atom that is, you know, the dominant atom in that tissue type, but rather how much of that atom is there. So we've got bone versus soft tissue versus air, and you know, in an escalating sense, you'll be asked on the test to pick out the tissue type from the least dense to the most dense, or the most dense to the least dense. So what you have is most dense. You have two different tissue types. You've got muscle and you've got other soft tissue, fat, right? So soft tissue types, which one of those is more dense? Muscle, right. So you go from bone to muscle to fat to air would be your descending from the most dense to the least dense in your density and ZEF number. So density is not the same thing as necessarily as thickness. It is, you can have two different tissue types with the same thickness, one much more dense than the other. So pathologies, we've got two different types of pathologies. We've got additive and destructive. Additive adds patient density. Destructive destroys patient density. So an additive would increase the effective Z number or the ZEF number, as opposed to a destructive would decrease it, okay? So additive pathologies absorb more x-rays, and they decrease, if you don't do anything to your radiographic technique, they're going to decrease radiographic density. Destructive pathologies decrease patient density, so they transmit more x-rays through the healthy tissue, and they increase density, radiographic density, okay? Remember, radiographic density and patient density are inversely proportional. So back to that. You're looking at an x-ray image. Bone. How does bone appear on the image? Very, clear, it's a light density, right? So how is it inside of the patient's body? Is it more dense or less dense inside of the patient's body? It's more dense. So if the tissue type increases density, radiographic density goes down, okay? So it's really, really important that you get that. As you increase patient density, radiographic density decreases, inversely related. So we have additive pathologies. We'll run through some of those here in a minute, but comparing additive and destructive pathologies, probably, or maybe one of the more drastic examples I've seen of a destructive pathology, it really wasn't a pathology so much, was I had a patient one time. I was in a training position. I was at UT on 271, and we were doing a chest x-ray on a lady who was above the elbow amputee, okay? So I don't know the history behind why she lost her elbow down, but all she had was a stump. All right, so what you'll learn as you go through surgery is that there's been a little bit of a shift. Back in the day, if they couldn't fix an arm, they just cut it off. And now, or if a patient was paralyzed, they had nerve damage, in a lot of cases they just take it off. But now they tend to not, for a lot of different reasons. If you've still got that stump there, it still serves some purposes. You take a piece of paper out of your notebook and you just write on it with one hand, what does the paper do?
Slide around.
Yeah, it walks all over the place. Whereas if you've got this thing, even though it doesn't, you can't control it, it can help you to hold your paper still, right? Well, they took this woman's arm off, so it had no function at all. So the reason you've got good bone mass at your age is because, number one, you hadn't gone through menopause yet. That's number one. You're not very old. That's number two. And number three, you're active. So you're up and moving all the time. But as you age, all three of those become, an issue. So your osteoporosis, your patient osteoporosis loses bone mass because of those things. So as long as you're active, your bones tend to be stronger than when you become inactive. So this lady lost her arm. She hadn't been able to use it. It had fundamentally no function, right? So we do a chest x-ray on her, and PA is not a problem, but we got to get a lateral. And because she hadn't used that arm, she lost flexibility in it. She couldn't move it either. All right, so we just had to shoot a lateral chest x-ray with her arm hanging down. And it had been so long and she lost so much bone mineralization in that arm, you couldn't see it on the lateral chest x-ray. Straight through the thoracic cavity, it was gone. You could see an outline of it, but it didn't get in the way of the diagnosis at all, just because, again, there was no bone mineralization, not much bone mineralization, and it was all fatty tissue. There was no muscle there either. So that would be a destructive pathology, decreases patient density to the point that you almost have no differential absorption. Increased radiographic density compared to the other arm. If we'd have left the other arm down, you could see a great difference between the two because it's still active, right? All right, so additive or constructive, and sometimes there's a little bit of an overlap between the two because sometimes you have two different conditions going on at the same time. So what is pleural effusion, PE? Air, it's fluid in the thoracic cavity outside of the lung in the pleural space, right? Well, what's supposed to be in the lung? Air, right? Is fluid, the Zeph number of fluid, higher or lower than air? It's much higher, right? So what would you need to do to compensate for a pleural effusion? You've got two choices. You got KVP and you got mass. What would you change? You would think so, but no. All right, so this is where it gets dicey. You're gonna have to increase something because you've got to increase in patient density. A very drastic increase in patient density, you lose radiographic density. Now, in some conditions where we increase that density, the patient density, we need to increase KVP because we need to increase penetration. But as we increase KVP, what happens to the interactions inside of the patient?
Get more scattered.
You get more scatter radiation, right? And what type of tissue creates more scatter radiation?
Fat or soft tissue.
Fat and soft tissue. What's fat and soft tissue made of? Huh? Fat and soft tissue is made of what? Water, fluid, right? So we've taken air, which doesn't absorb really anything, and lung tissue, which doesn't absorb a whole lot, and we've replaced it with fluid, which creates a lot of scatter radiation. If we increase KVP, we compound the problem, right? So sometimes it's counterintuitive. You know, if our pathology is caused by an increase in fluid, then we need to increase mass instead of KVP, even though we get an increase in Zeph number. So logically, you're gonna think, and it is a logical conclusion, that if you increase Zeph number, you need to increase penetration. But what's causing that increase in Zeph number? Is it fluid? And if the answer to that is yes, then your go-to adjustment is always going to be mass. Okay? And some are additive conditions, but you really don't need to change your technique in most cases, like a pneumonia. A pneumonia, most of the time, is just going to be localized, most of the time, relatively small patch inside the lungs. And we've got something that adds density, so it is additive, but really the amount of additive tissue that you've got going on there is not significant enough to increase your overall technique. Does that kind of make sense? It's still additive. Is there a technique adjustment? Not really, unless it's a massive, massive pneumonia. You know, if it's a huge pneumonia, then you might want to change your technique. In that case, what would you change? I would just walk through this. What's a pneumonia going to be? Fluid, right? So your technique adjustment is going to be mass, right? What about casting material? Land's casting material is complicated. What'd you start saying? Somebody?
I was going to say you increase KVP.
Well, it depends. It depends. And we've got two different types of casting material. We've got plaster cast, which is hard to get through. And then we've got fiberglass, right? So fiberglass casting, if it's dry, you know, if they set it maybe a week ago and they're doing a follow-up just to see how it's healing, there's no technique compensation for it. If it's wet, then it's going to absorb some x-rays because it's fluid, right? So you may have to increase your technique for a wet cast, but if it's plaster, you're always going to have to increase your technique. So with plaster cast, you're going to be looking at double the mass, maybe 15% increase in KVP, something. It's significant, and it's even more significant if it's wet plaster. Okay? So wet plaster, increase a lot. Plaster, increase still a lot, just not quite as much. Wet fiberglass, increase your technique a little bit. Some cancers are additive, some cancers are destructive. Lung cancer is additive, and it kind of follows the same rule as pneumonia. If it's a huge cancer, lung cancer, you might have to increase your mass. If it's a small lung cancer, probably not. If it's a bone cancer, though, bone cancers are destructive, right? So you look at an x-ray and patient's got a bone cancer, and what you're going to see is a thinning of the cortex of the bone. It gets eaten away, right? And it doesn't look like osteoporosis. Osteoporosis, the whole bone, you lose density. And a cancer is going to be a localized spot, and it just looks like something's been chewing on it. Aneurysm, bulging of an artery, and really no technique compensation, but it is additive. What is atelectasis? What's the word mean? I know this. Huh?
Isn't it fluid?
Inflammation.
You're thinking ascites. Somebody else?
Inflammation around the spinal cord?
No, you're thinking myelitis. So what atelectasis is collapse of lung. All right? So what would you do with your technique for a collapse of lung? This is really a trick question.
Nothing.
Maybe. Maybe something. Right? Well, what caused the collapse of the lung? It's an additive condition. Atelectasis is an additive condition because you've got this much lung tissue that you've compressed down to a small area. But what caused the collapse of the lung? Is it PE? Would fluid displace the lung and cause the lung to collapse? Absolutely, in which case, what would you do? Increase mass, right. But what else might cause the lung to collapse? A puncture, pneumothorax, right. So in pneumothorax is not additive, it's destructive. So what are you looking for on the pneumothorax? If it's a 10% pneumothorax, which is very small, it's going to be difficult to visualize, and if you increase your technique because you're thinking, why the patient's got atelectasis because of the pneumothorax, you might burn out the pneumothorax and not see it. So what's causing the pneumothorax, or what's causing the atelectasis? Is it pleural effusion, in which case you'd increase, or would you decrease because it's caused by pneumothorax? So ascites we walked through, osteopetrosis we did not. Osteopetrosis is kind of like the opposite of osteoporosis. All right? Now we've got an addition of bone. So if our bone gets significantly more dense, what's that going to look like on the image? Is it going to affect the appearance of the soft tissue? But what is the bone going to look like? Is it going to get darker? It's going to get lighter, right? Now, we have a ZEP number increase that's not related to fluid. So what would you increase?
KBP.
There you go, KBP. If the patient had prosthesis, you know, they got a hip replacement or a knee replacement, you may have to increase KBP. So if it's something that's not soft tissue and it's an additive condition, then you would increase KBP. But if it's soft tissue, you would increase mass. Acromegaly kind of follows osteoporosis. Acromegaly occurs whenever a patient has a pituitary tumor. And in adults, you know, in children, if they develop a pituitary tumor, then what they're going to get is giantism. So you've seen these, some of these people that are like 7, 8 feet tall, and in a lot of cases their jawline just extends, so they got this massive underbite. That is because the pituitary controls growth hormone. So if you develop a pituitary tumor before those growth plates heal up, you wind up really tall. Guinness Book of World Records, the tallest man, you know, since they started the Guinness Book of World Records, was almost 9 feet tall. You'll see pictures of him, right? He was a shoe salesman, but he's almost 9 feet tall. And I stood next to a cardboard cutout, life-size cardboard cutout, and I came up pretty much to his belt. I mean, this guy was huge, and that's what happened, is he developed a pituitary tumor before his growth plates healed up, and he just got massive. But if it happens afterwards, remember you got two areas of ossification. You got primary centers, which are like the diaphysis of the bone, and then you got secondary, which are at the epiphyseal plates. So if it's after the patient, you know, their growth plates heal up, then what they get is an increase in bulk, right? So the jaw, because your primary centers are going to be anywhere along the ramus and the body of the mandible, you'll still get that underbite, but you just won't get the size. Fingers will get fat, arms will get fatter. You get an increase in bone tissue, so like osteoporosis, or osteopetrosis rather, and you would need to increase your KVP. So additive pathology is just an example. We've got what should be normal, healthy lung as opposed to completely opacified lungs. In this lung, you see how you can't really see through that very well? Now you can see through it too well, I guess is what I should say. You can't see in lung monkeys, right? That's what happens whenever you put when you're phototiming and you put something over the photocell that shouldn't be there, basically. So in this case, your machine is expecting a chest x-ray and you utilize the outer two cells, and this one had to run continuously for a while until it got the right density, which burned this lung out, right? So taking this in the opposite direction, if you're taking a chest x-ray on a patient, lateral chest x-ray on a patient, and you use the outer two cells, where are those outer two cells going to be in relationship to the patient's anatomy unless the patient's really thick? In front of and behind, right? So you shoot a lateral chest x-ray with the outer cells activated, what's your image going to look like? Is it going to be overexposed or underexposed? Yeah, you're gonna make that leap too. It's going to be underexposed because those cells are going to receive direct radiation. They're going to shut off really quick. Okay. You need to hang on to that all the way through the registry because almost every registry review book has a question like that on it. You shoot a lateral chest x-ray with the outer cells activated, you get underexposure, gross underexposure. So destructive pathology, it goes in the opposite direction. Most of your technique changes, most of the time, if it involves mass, is going to be a 30 to 50% increase or decrease in mass. So for most of your additive conditions, it's going to be a 30 to 50% increase in mass. For your destructive conditions, it's going to be a 30 to 50% decrease in mass. So it decreases as F number. TB would be an example. Atrophy, that's what we had with the lateral chest x-ray with the amputee. Pneumothorax, emphysema, rheumatoid arthritis, and osteoporosis. So what you need to do is check the chart, check with the nurse, take a history, look for your telltale indicators, walk through all that, consider conflicting possibilities. Are you shooting chest x-ray for a central line or are you shooting it for pneumothorax? It makes a difference. If you're shooting it for a central line, you may need to increase your technique, and in this case, you could theoretically increase your KVP just a little bit, maybe a 5% increase, or a pneumothorax, in which case, if you're trying to decide between a couple of techniques, always go with the lower of the two if you're looking for pneumothorax. All right, so we'll walk through this already. When to use KVP. That is, if you need to change differential absorption in tissues that are not fluid type, right? And most of the time, it's going to be a change in mass. So KVP sometimes, most of the time, it's going to be that 30 to 50% change in mass. KVP, rarely. So when to use exposure timers or exposure time to compensate? If you're at a total loss for a technique, and you're phototiming, I'm sorry, it's exposure time, but if you're phototiming, you've got two possible, if you needed to repeat this, let's say, you got two possible ways that you can adjust for the technique so that you can see this long time, okay? One, turn that photocell off. Right? Two is, those little buttons on your control panel that say +1, -1, things like that. Well, the +1 would increase the density even further. So what you're trying to do with the -1 is to remove some of that density. So the -1 removes radiographic density, lowers your technique. Okay? So, there's that. So when to use exposure time? Really, exposure time is the easiest way to adjust your technique and fine tune your technique with that 30 to 50% change. But it comes with risks, you know. The main thing that's going to destroy your patient or your radiographic image of sharpness of reported detail in your image is patient motion. So the longer you drive up your patient or your exposure time, the more likely you are to introduce motion, right? So you can use that, but you know, understand it comes with risk. But sometimes there are times when you want to introduce motion, breathing techniques, right? So you would decrease your MA and increase your exposure time. Or sometimes you have to use KVP, a reduction in KVP to extend your exposure time. Let's say you're doing a portable C-spine for whatever reason, T-spine, let's say, T-spine. Portable T-spine on a patient. For whatever reason, the patient can't come down to the department, but you need to get a lateral T-spine. What do you want with a lateral T-spine? What's your technique? What do you use? I don't mean specifically, in general, for a lateral T-spine to eliminate some of the rib markings and lung markings, what do you use? Okay, 80 kVp and what? Somebody, did you say long time? Long exposure time, somebody? Okay. So long exposure, yes, long exposure time, so that you can utilize the breathing technique, patients, you know, breathing in and out throughout the exposure. But how do you adjust your exposure time on a portable? What kind of timer does a portable have? What's that? If you're you may be working with one with automatic exposure control. They have them now. They didn't have them back in the day. The timers on portables are, you know, the safe space and weight on the portable machine are generally mass timers, right? So you adjust your KVP and you can adjust it to whatever you want it to be, but your mass is not separable into MA and time, right? Anybody working with a machine that you can select MA and time on your portables? No, I didn't think so. So, the only way that you're going to get a long exposure time then, it's going to drive patient dose through the roof, is to decrease your KVP. You decrease your KVP and you can increase your mass. On a mass timer, what you've got is a set MA, and what you're actually doing is adjusting your time whenever you run through the mass settings. Okay, so it's probably set to a 100 MA station, and you're just adjusting your time. So sometimes, you know, it's appropriate to use long exposure times. Most of the time it is not. You're just almost out of time. So a couple of things. We're going to run through this slide and then we're going to call it quits. When to change your SID? One is whenever we change our OID. If you increase your OID and you don't want the magnification, there are times we'll want the magnification, but if you don't want the magnification, you increase your SID. You increase your SID and it brings that down. Sometimes you need to increase your SID, not because of an increase in OID, but rather to reduce the magnification anyway. What I mean by that is, anybody shot any AC joints yet? Pretty rare. AC joints are acromioclavicular joints. And textbook says shoot them at 40 inches, but I'm telling you, if you've got a patient with any kind of width at all because of the divergence of the central ray, you're not going to get the AC joints on a 14 inch wide image. 17 by 17 maybe, but a 14 inch wide, you're never going to get them. 17 is even going to be dicey. Okay, but if you back up to 72 inches, then that divergence is not quite so bad, and you can actually get both of them on almost anybody. Okay, so when magnification needs to be reduced, or when air gap is present. So when do we use a grid? Grids we tend to use in two different cases. One is if we're using a higher kVp in the absence of an air gap. So, abdomen, we might use 80 kVp, we need a grid. If it's above 70 kVp, we need a grid because we create enough scatter radiation that it warrants use of grid. 10 centimeters or more, general rule of thumb is shoulder size or knee size or above, we need to use a grid. So we're going to get into grids later in the semester, but the grid use is, the purpose for the grid is to absorb scatter radiation, and that, we'll talk about technique change whenever that happens. So, focal spot size, you should see no difference in your technique whenever you change from large to small focal spot. And this is what you're going to have a tendency to do. It's just a little bit of a leap, but you're going to think, okay, I got a filament this big and a filament this big. Okay, so logically, this big filament can create more electrons than a filament that size, right? And you would be right. But what we're talking about in our technique is kVp and MA, and MA is just count of electrons, okay? So if you can fit this number of electrons on a filament that size, your mass shouldn't be any different between large focal spot and small focal spot. Does that kind of make sense? The mass does not change between large and small focal spot. Now there are times you can't use a small focal spot because of the mass you selected. If you try to set a technique with 400 MA on a small focal spot, your machine's gonna say, no, that's way too big of an exposure on this little bitty filament. You're gonna have to reduce either reduce your MA or use a large focal spot, okay? But your technique, as long as your small focal spot will make the same exposure in mass as your large focal spot, you should see no difference in your exposure. Then filtration, realistically, you're not going to see a change in filtration unless you are working in a hospital where you routinely x-ray children, like scoliosis series or something like that. But in general diagnostic hospitals, you're never going to change your filtration. Now, your filtration will change because you've got tanning of the tube, but you aren't going to add filtration or remove filtration specific to the exam. Okay? Any questions? Okay, so we'll finish this up on Friday, and then we'll have the positioning test on Monday. Open discussion questions in both of the Canvas courses. We'll have positioning test on Monday. We'll have the midterm test on Wednesday, and if you have any questions on all of this on Wednesday, because the midterm test shouldn't take you more than about 30 minutes tops. So if you have any questions on this, then we'll talk about those, and then we'll have this test on Friday of next week. Okay? Good luck on your test.